the floor
Thank you, Christos.
is yours, as they say. Thank you.
Thank you, Christos. Thank you, everyone, for being here. And so can I share my screen real quick so that you can all look at my slides? Is it visible now?
Yeah.
Yes, it is.
Yeah, okay. All right, perfect. So this is joint work with Adnan Fakir, who I think has joined the meeting as well. So just in case I can't answer any of your questions, then I'll ask Adnan to jump in real quick. Let me begin by stating the obvious, the reason why we're here. COVID-19 has changed the world dramatically. In addition to the 8 million lives affected due to infections and the over 400,000 dead, we also are receiving reports about increasing mental health issues, a rise in domestic intimate partner violence. Those are the micro level changes that are coming along, but the economies, so there's an economic downturn that's headed our way, has already started. Economies are restructuring. The looming threat of automation, which people were scared about, now seems to have been expedited because of the COVID-19 pandemic. And at a much bigger global scale, there are international relations that have been soured and that have been strained because of the pandemic, the situation between Australia and China being the case in point. But countries have responded. It's not like countries haven't responded. What we have now are perhaps the biggest state-led mobility and activity restrictions in the history of mankind. However, there is a debate raging that whether countries were too slow to respond and the response was insufficient, or whether it was too extreme. So on one side, we have, there's an article in the Lancet, which was published in March 2020, which argues that countries were slow and the response was insufficient. But on the other side, we have people like Martin Revelin or Gigi Foster who have been arguing that perhaps the restrictions were too strict. They will lead to an economic loss that will be much bigger or much more harmful than the COVID pandemic itself. So what is the answer? Was it too little or too much? So that's what we focus on. And obviously that depends on how effective these measures were in terms of controlling the pandemic or controlling the contagion. Historically, we know from experience and from research that they don't always succeed. These restrictions don't always succeed in achieving or controlling the contagion. There are quite a few papers, one about Ebola recently, where when people were constrained in terms of their movement, that deteriorated the situation in the constrained neighborhoods even more. And simulation analysis shows that if they would have let people go to different places, perhaps the burden on the health infrastructure of the region would have been somewhat lower, and people would have been could have been catered to. But besides that, it's also these kind of measures are extremely costly and controversial. We all know about the economic costs, but there's also some other trade-offs to keep in mind. Well, if we reduce the infection, well, that benefits the physical health of people, but isolation, as we have come to know, leads to mental health issues in the rise. There are reports that suicides are rising around the world, and some of it could be attributed to the isolation's requirements that are in place. There's also a trade-off between lives lost today versus tomorrow. So, if we reduce the infection spread, we control mortality and morbidity today, but the economic downturn will have implications on the consumption and income of people, which down the line will affect the mortality and morbidity of people. And then there's this debate that's raging about where, the trade-off between the welfare of the old who have perhaps lived their entire life or are close to have lived their entire life, and people who are young who haven't and are suffering because of the economic downturn much more than because of the infections per se. And I'm not taking any sides, but these are trade-offs that one has to keep in mind when evaluating the effectiveness of of these restrictions. What I want to add is obviously these costs, the economic costs in particular, are much more salient or are much higher in developing countries, where a greater proportion of people are reliant on informal sector jobs, casual labor, or subsistence activity. The moment the economy closes down, these people are struggling to afford their level of consumption, and that could have implications on their immunity and therefore the spread of the contagion directly. So the question that we ask in this paper is quite simple. We want to find out the causal effect of the mobility and activity restrictions that were in place around the world on whether or not they contain the contagion, or to what extent do they contain the contagion. And we also want to look at what factors might mediate that relationship, what factors might make it more effective and less effective. And so let me begin by telling you all what we know. You might already know this. We know that there's a negative association between restrictions that were implemented after the COVID pandemic and the spread of the contagion. So there are a lot of studies now which show correlation between these two variables, or they do simulation exercises where they predict that restrictions will have a causal negative effect on the spread of the contagion. Which is not surprising, but the problem with this line of research, or the limitation per se, is that associations can be misleading when we're thinking of mitigating policy. The reason being that if, suppose, you are a population that is really circumspect, and so you start social distancing even before the government has put any strict restrictions in place, and that might actually put pressure on the government to then come in and impose these restrictions. But the decrease in contagion might have happened because you personally took precautions, and not because the economic restrictions or the mobility and activity restrictions were put in place. So that's why what we are interested in is in the causal effect of these restrictions. There have been a few attempts to identify causality here. And most of them have used a difference, or all of them have used a difference in difference methodology. So what they do is within a country, they compare regions with high or low levels of restrictions. So United States is usually the data from United States is what they use. And they do find, again, a negative correlation between, or negative association between restrictions and the spread of the contagion. But the problem there is, methodologically, it's a problematic exercise, because if you are doing a difference analysis, the key assumption is a parallel trends assumption. And as I mentioned, that regions which are more circumspect, or governments which are more circumspect, will be more likely to implement, or more likely to engage in early action, implement stricter measure early on. And they might also have population where the spread would have naturally been lower because of other precautions that they take. So the parallel trend assumption underlying difference in difference methodology seems to be violated in this case, if you do a difference in difference evaluation of the restrictions. What we do is we use an instrumental variable technique. So our identification relies on the insight that governments, when they were deciding whether or not, or how stringent to be with their restrictions, they looked at two things. They looked at how bad the disease environment was at home, right? So, and that's basically the reason, that's basically the variable that confounds difference in difference methodology. But the other thing that they looked at is they tried to make predictions about what the world or what the condition would be like if they did not implement those stricter restrictions. They had no way of, they did not have perfect foresight. They couldn't have predicted what would have happened in the counterfactual scenario. So what they did is their expectations were based on actions taken by other countries. So if, suppose, a country was in the region where everyone else was coming up with stricter and stricter restrictions, the country had higher pressure from outside and from within the country that we should perhaps do the same thing. And we'll show you that that seems to be the case, that the restrictions in a country C, for example, will be affected by how strict the restrictions are around the world at the same time, or around the same time. So just to show you the identification strategy in a figure, here is what we have. We have stringency in country C at date T will be affected by stringency in other countries at date T. And that will affect the change in, say, mobility or how the contagion spreads in country C on date T. But the stringency in other countries will not directly affect the rate of spread of the disease in country C, right? So that's why we think, so this basically says that the exclusion restriction that you need for the IV is likely to be satisfied, and it is also likely to be a relevant IV. All right, so given that, so the empirical specification in short would be, we'll predict the stringency in country C on day T with stringency or average stringency in the rest of the world except country C at day T, right? So that's where the pressure argument comes in, that what the world is doing informs your decision to some extent, or you base your predictions of the counterfactual scenario based on what the world is doing, and you try to follow what the world is doing. And then we use this predicted value, the predicted stringency in country C at time T, as the independent variable for our second stage regression, where we will be regressing the mobility, the changes in mobility, so the growth rate in mobility over time in country C at time T, and the growth rate in the spread of the disease, so the number of tests done, the number of confirmed COVID cases, the number of deaths attributed, and the number of deaths attributed to COVID, right? And we expect that when stringency is higher in this country, then it should have a causal effect on mobility and deaths and the number of confirmed cases. One thing that we'll do during our analysis is that even though when we are looking at mobility, we will look at contemporaneous stringency restrictions. So because we expect that whatever the stringency restrictions are today will affect how people move around the country or within the country. But when we are looking at the number of confirmed cases or deaths, we will take lags of stringency as an independent variable. So the idea there is that the current understanding, scientific understanding, is the incubation plus the infection period of COVID continues almost as long as 14 days. So it makes sense that stringency in the past will have an effect on cases today, or stringency 7 or 14 days ago will affect the number of cases or the growth rate of cases today. So a bit about data. So we will get our stringency data from Oxford COVID-19 Government Response Tracker. They collect daily country level data. And they make an index out of it to present how stringent the restrictions were. The index weight goes from 0 to 100, 0 being the least stringent and 100 being the most stringent. It's based on multiple factors. It's based on whether schools were closed, whether workplaces were closed, whether public events were cancelled, or whether there were restrictions on public gatherings, and how stringent were those restrictions, whether public transportation was closed, whether there were stay-at-home requirements, internal movement restrictions, so whether you can go from one district or one region of the country to the other or not, international travel controls, who can travel, who can fly outside the country, and public awareness campaigns, so whether there were programs where people were told what are the best practices in case you're infected by COVID. Keep in mind that just because this stringency index doesn't reflect compliance, so it could be that a country has real stringent policies in place, but if the population of the country is not compliant, then basically it might not have an impact. So, and that's what we'll test in the first set of results, that whether or not it affects people's mobility within the country. The mobility data that we'll be using to test whether people comply to these restrictions or not will be based on Google Community Mobility Reports. So this is available for 131 countries, and we have it from February 15 till May 10. It basically tells you the percentage change in traffic around 6 major locations, 6 location types, relative to what the traffic in those areas was in the 5 weeks between Jan 3rd to February 6th. Right, so it's a relative measure. The benchmark is the 5 weeks between January 3rd to February 6th, and how it changed over time relative to that benchmark. And the 6 locations that they give you data on are groceries and pharmacies, retail and recreation centers, parks, public parks, transit stations, workplaces, and residences. So we expect that mobility will go down at all these places except residences, because people are moving, people are staying home more often. For COVID-19 related data, we will get the tests conducted per million data for 78 countries from our world in data. And we will use the Johns Hopkins Center for System Science and Engineering data repository for cases and deaths per million for 117 countries. Of course, there has been selected testing and underreporting of these cases and the deaths or recoveries related to COVID. And we are very well aware of this. What we can say in that regard is, first, if underreporting of the measurement error in these variables are related to countries' characteristics, we will control for that using country fixed effects. So we'll have country fixed effects in all our regressions. So that takes into account the differences across countries and the dependent and the independent variables. But the problem is that with country fixed effect, we can control for time invariant differences. So if the underreporting remained the same for a country throughout this period, or the other sources of measurement remain the same, then we'll be able to control for it. But in case the measurement error itself changes across time for a particular country, for within a country, we won't be able to count for that. And therefore, the results that I show you'll have to take it with a grain of salt. We will use country-specific characteristics for a variety of sources, mostly World in Data and World Bank indicators. And there's a full list of that in the appendix table if you want to take a look at that. So let me quickly jump onto the results. Okay, so this is basically how restrictions affected mobility. So here the columns are mobility at different locations in a country. Or across country. We do a cross-country analysis. So these are measured for each country, one measurement for each country on each date. And in the first panel, the independent variable is what is the level of stringency on that particular day on which these outcomes are measured. In the second panel, the independent variable is what was the level of stringency of the restrictions 7 days before these outcomes were measured. And similarly, in the third panel, 14 days before these outcomes were measured and 21 days before these outcomes were measured. So two main takeaways from these tables. There are a lot of numbers, but there are only two main takeaways. First, the restrictions had an impact on mobility in the direction that you would expect it to. So the mobility decreased at retail and recreation centers, groceries and pharmacies, parks, transit stations, people were traveling less, at workplaces as well. So the offices closed down or people who are working from home. And there's a corresponding increase in traffic in residential areas. So that basically says that people are staying home more often. The other takeaway from this table is that contemporaneous measures matter more, stringency matters more. So as you go down, as you take into account lax stringency, it seems like the impact of lax stringency on mobility in the current time decreases. And stringency 21 days ago doesn't even matter. So those are the two main takeaways from this table. And what I'm not showing you here, because it made the table even more crowded, is that there is a significant difference between the OLS, if you run a simple correlation regression, and the IV estimates. So the IV estimates that we have here that I showed you are much bigger compared to the OLS estimates. Sometimes in some of the newer specifications that we are running, they are almost double the OLS estimates. So if you looked at just associations, that would that will give you a lower bound, or that'll bias your effect or estimate of the effect of stringency on mobility downwards. So next, obviously, so just because mobility decreased doesn't really mean that the number of cases or deaths or the growth rate in these will also decrease. And that's that's close to what we find. We find that if you look at stringency in the current time or contemporaneous stringency, it doesn't seem to affect the growth rate of cases or deaths or tests that much. The growth rate of cases is slightly negative, some significant, marginally significant, but what matters more is stringency 7 days or 14 days ago. So if your country was really stringent 7 or 14 days ago, the growth rate in the number of cases will drop down now, right? And which is consistent with the scientific understanding at the moment that it takes a bit of time. There's an incubation period of around 3 to 4 days from the point when you get infection. And then obviously there is a period through which the infection stays in your body, and then the virus dies off, or the virus is expelled from your body. Stringency 21 days ago doesn't matter, which is kind of, again, consistent with the scientific understanding that 21 days after your infection, the virus is already out of your body to some extent, or you can't, if you have been properly isolated, the chances of you infecting other people has decreased drastically. So that's what we find from this, that there is a significant negative effect on the number of confirmed cases and deaths of restrictions, but these restrictions in 7 to 14 days ago matter more than contemporaneous restrictions. And in terms of testing, I want to show you this, that the effect is more significant and negative for cases and for the change in the death rate due to COVID-19. It doesn't, well, there is some effect on the number of tests done by countries, but it's not significant throughout, and it's weak at sometimes. It's not very consistent. So we don't want to make a lot of claims about how the testing changed due to stringency. So we'll focus on the number of cases, the rise in the number of cases, and the deaths that were attributed to COVID-19. All right, so now what we want to do is basically we want to see that, okay, fine, were these measures equally effective across all countries in terms of how effective they were in terms of reducing mobility and in terms of reducing the spread of the pandemic? And to do that, what we do is we pick a bunch of country level characteristics like population density, poverty headcount ratio. So that's how poor or rich a country is, or how unequal a country is. And we split these countries at the median, right? So lower than median is all those countries where the population density is lower than the population density of all the countries in our list, and similarly, higher than median. And when we do this analysis separately by, say, high and low population densities, or low poverty and high poverty regions, I'm putting these tables here so that you can see the results, but I want to jump quickly to what we find, because there are quite a few of these results. We do it by population in the country. We do it by the health condition or the cardiovascular disease death rate in the country. We do it by the age, the demographic profile of the country. We do the analysis, the heterogeneity analysis by hospital beds. We also do it for hand washing facilities, how democratic a country is, how effective the government are, a lot of different variables. And the main takeaways from that I have summarized here. Stricter restrictions tend to work better in densely populated, poor, more unequal, more polluted countries. It also works better in countries which have younger population, but that also have unhealthier population, and that have worse health infrastructure. So when you take this all into account, together, these paint a picture which looks very similar to that of developing countries, right? So it seems like stricter restrictions work better in terms of decreasing mobility in developing countries. So that's one set of results that we have. The other thing we do is, okay, so what happens? What is the heterogeneity in the impact of restrictions on the number of cases growth rate, or the number of deaths growth rate? And there again, we do it by a bunch of different.
Tushar,
yeah.
2 minutes.
Yes.
2 minutes,
Yes.
please.
Oh, sorry. Okay. And
That's
what
right.
we find, again, I'll summarize that for you, that we find richer countries, more equal countries, less polluted countries with older but healthier population, and countries with better health infrastructure, they have a bigger impact of restrictions on the control of the contagion. So we find, on one hand, we find the restrictions affect mobility more in developing countries, but it affects the contagion or controls the contagion better in developed countries, right? And what we do is we can actually then go on to calculate what is the effect of reducing mobility, not of imposing stricter restrictions, but reducing mobility in different countries. And to do that, what we need to do is we already have the estimate of how stringency affects the growth rate of cases. We already have the estimate of how stringency affects mobility. when we take the ratio of the two, we can actually calculate how mobility, decrease in mobility, will affect the growth rate of cases and diseases. And this is what we do in this table. So these numbers are basically telling you how effective our reduction in mobility at decreasing the growth rate of cases and deaths in countries with less than median population densities. Again, a lot of numbers, so let me summarize it. What we find is the following, that reducing mobility works better in developed countries, right? So even though having stricter restrictions will decrease mobility more in developing countries, that itself will not have a lot of impact on the control of the contagion in developing countries. And which kind of makes sense given the literature at the present moment. Stringent restrictions, for example, cannot counter immunodeficiency, right? If people are immunocompromised, which like there's a greater proportion of immunocompromised people in developing countries, they can't fight off the infection even if you leave them at home or even if you isolate them. Similarly, these restrictions have economic cost. It can affect food consumption in developing countries much more than in developed countries, and that will directly affect the immune of people and therefore their ability to fight off the infection. Again, hand wash and sanitizers, as Evelyn points out, is not on the top of the shopping list in developing countries. So even if they are at home, they don't have all the necessary infrastructure to be able to fight this infection. There are other reasons why flattening the curve is only marginally useful in developing countries where the health infrastructure is already overwhelmed. And there's also a lack of awareness in developing countries. So yes, you have been quarantined because of the infection, but what do you do after that, right? And people don't have the information about the best practices to follow in case somebody in their house is infected or they themselves are infected. So let me quickly conclude. So what we find is mobility restrictions are not sufficient in developing countries, or in some recent work, we find that even in poorer areas of developed countries, they're not sufficient. That is not to say that you should not have them in place. You need them. But you need to complement these with other measures, especially because the economic cost of these mobility restrictions is much higher in developing countries. So you need to complement them with awareness, spreading awareness about the best practices, and some sort of economic and health assistance so that they can at least maintain their level of consumption and their immune is not compromised even further. What can these policies be? We don't know, and hopefully future research will try to find out what's the best policy to provide these kind of assistance. And then there's the related question of how to fund them, right? Because there is an economic downturn, and we are proposing that you should give economic assistance to the poor. How do you fund them is a big question, and hopefully future research will look into that. We do want to say that the pandemic has global long-term costs, right? So even if China is the only country that's infected, if it's infected badly, the cost of production will increase tremendously, and that'll affect all countries, developed or developing. So it's a global cost, and therefore the solution has to come from a global cooperation. Maybe countries less affected and richer should help developing countries to tackle the situation. This is also not the last pandemic, and the vaccine is still nowhere in sight. So we need to optimize our current response to COVID, not just to save lives today, but to be better prepared for future pandemics. And that's why I think the cost-benefit analysis of such policies is really, really important. Thank you. Thank you. That's all I had.
Thank you, Tushar. This is really interesting and of course, highly topical. I've got a number of questions, but unfortunately, time has run out. I can squeeze one or two, but I think you might not have the time to respond. So what I'm going to do is, maybe in the break, or I'm going to pass the questions on to you later on. In any case, but thank you. That was fascinating.
Thank you, Chris.
Now we have a change over now, so there's going to be kind of a 10 minutes break. But in the meantime, too, so you can stay if you want until we do that.
Yep.
And I'm happy to pass on the questions to you. Either you respond, people are still online, of course, and you can respond again now if you want. But before I do that, I mean, the next presentation is going to be by Enrelt Mukarami. She's based in Ogata Research Institute in Tokyo. And the talk is going to be on the potential impact of the COVID-19 pandemic on the welfare of remittance-dependent households in the Philippines. Okay. Now, Tushar, let me go back to the questions, please. One question was about, you might not see that, it was about external validity, okay, of the results. I think that's a very interesting sort of a valid question to ask. The other one was on the whether you're taking into account the peculiarities of African countries that have, you know, understandably a very low test rate, okay, per day, given capacity, hot temperature and poor healthcare system. And the next one is, what is your view on that the mobility data may record very different subsets of the population in different countries? You know, how would that affect, okay, your results?
Yeah. So I'll start with the last one first, which was about the mobility data. So what we do in our analysis is we are not comparing one country with the other. We have a country fixed effect in place. So what we are doing is we're comparing countries at different points in time. So to the extent that the mobility data is available, even from a smaller population from those countries, we are comparing those populations. So that goes back to the external validity question, that perhaps we are not capturing the entire country, but within that country, we are capturing the same set of individuals over time. Whether that's a good representation of the country, I don't think so. In fact, in developing countries, less number of people will use smartphones, which will basically give a smaller set of mobility data for these countries. And I think that if you had mobility data on all countries, you'd find that the impacts are even bigger, because of course, like the poorer people who are not using mobile phones to record their movement, they are even worse hit. I mean, their livelihood has been taken away. So I think it'll be bigger, but you know, I'll take any suggestions as to how to make this analysis better. Next, there is a question about the African countries' peculiarities. Well, it's pretty interesting because we do have country fixed effects, so we are actually accounting for the fact that countries are different. But if you look at the heterogeneity, the fact that many of the African countries will lie in the low or less developed bracket, less developed group, tells you that the African countries are having a very different experience in terms of how restrictions are affecting the pandemic, the spread of the contagion compared to other countries, right? We could do an analysis where we club African countries, as a continent, Africa separately, and compare it with other countries. But I think the main results will not change much. So to answer your questions, we are taking that into consideration, and I think that the experiences of Africa are very different. The one about external validity, I already answered. There's one more coming in about Google mobility data covers only population that has their phone open most of the time. Maybe this does not cover, yeah, exactly what I said, that, yes, it doesn't cover the poorest part of the world. And I think the impacts are even more. So if you look at the heterogeneity analysis, where we find the impact on mobility is even higher for poorer countries, I think if you had data in a counterfactual scenario for all those people who didn't have mobile phones, smartphones, you'll find an even bigger impact on mobility and a smaller impact in terms of reducing the spread of the contagion. So I think I answered all of them.
Good, thank you, excellent.
Thank you.
Thanks a lot, thank you. Right,